The Knowledgeable Provider podcast is intended primarily to entertain, also to inform, but it is not a substitute for actual medical training and should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, please make an appointment to see your own knowledgeable medical provider. The opinions expressed by me and anyone else who happens to appear on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than the lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. Look, this is all for fun, okay? Don't sue me. All right, on with the show. Hello, welcome to Knowledgeable Provider. I'm your host, Jody Marks. Today I have the pleasure of speaking with my friend and mentor, April Klar, who's managed to have a very long career in a busy ER that tends to chew up nurses and spit them out. I know I could never work there for sure. So I want to know the secret. I wanted to talk to April about her longevity in the field. And of course, we end up talking about a bunch of other stuff as well. She's such an interesting person. Unfortunately, my computer just decided to pretty much fail right in the middle of this interview on toward the end of it. So of the 3 recordings that I usually have, only the backup Skype recording survived. And I'm thankful I didn't lose the conversation, but the audio quality is not exactly as good as I would prefer. So hopefully that's not too much of a distraction. So without further ado, April Klar, welcome to Knowledgeable Provider. Thanks so much for your time.
Yeah, thanks for having me.
Would you like to introduce yourself to the audience?
Well, I am a nurse practitioner currently working in emergency medicine, and I have been doing this for about, I guess, a little over 20 years now. I was formerly a flight nurse and flight medic, and I've always enjoyed emergency medicine and kind of everything that goes along with it.
20 years, that's amazing.
Yeah, I kind of joke and tell people I was a child prodigy, so they don't really know how old I am, but I can't believe it's been 20 years either.
Have you been in the same ER the whole time at Huntsville?
So when I was we say baby nurse, they would not allow new grads in the emergency department. So I actually worked on a cardiology floor for a little while, and then I transitioned to a smaller ER and worked there for a few years, and then transferred to the ER where I am now.
Gotcha. Okay. How long did it take for you to make it to Huntsville ER?
About 3 years.
Okay, got you. And level 1 trauma center, right?
Yes, exactly.
Yeah, big deal ER. I guess that's one of the main things really I want to talk about is your longevity in that field. I don't know the statistics, but I get the feeling that there's probably a lot of turnover, probably not a lot of people spending 17 years in the big, busy ER like that.
Yeah, I'm probably somewhat of a unicorn. There's a few of us that have been around that long, but not many. Tough place to work, and burnout is very high.
Sure. Yeah. What are the things that make it tough in your eyes?
Well, I've noticed a big change over the last probably 10 years or so. The patient acuity has gotten a lot more intense. The patients are sicker. Our population's living longer, so people have a lot more comorbidities, and the sheer volume that we have has made it's very challenging.
Sure. Yeah. Has there been a big change since COVID or because of COVID that you picked up on?
Oh, absolutely. With COVID, there was a big shift. A lot of people, I think, were scared. Nurses were scared. They decided to leave the bedside, which has left us with a national nursing shortage, and we're definitely paying for it now. The ER is short, the inpatient floors are short, so we're boarding patients longer and longer in the ER, which is a dangerous situation. And for the first time in my career, we're having, ambulance patients that come in with nowhere to go, and we call it sitting on the wall, but they sit on an ambulance stretcher for an hour or two until we have a place to put them.
Sure. Yeah. And I know HIMSI's kind of adjusted their procedures so that they can have somebody sitting there watching their patients before they're turned over to the ER so they can get the trucks back out in the field.
Yeah, they're generally leaving a supervisor to watch over the patients until we can do a formal handoff.
Sure. Yeah, that is way different from when I was involved in all that. It was like kind of unusual if you waited more than 10, 15 minutes to get a bed and you were pissed off at that point if it hadn't happened by then.
Sure, yeah. We used to never keep our EMS waiting, and it, used to be people would abuse the system and they'd say, "Oh, well, I'll get back faster if I get in an ambulance." And that's just not the case anymore. It's a very different world.
Yeah, I imagine so. What kind of hold times are you seeing in the ER? How long are you having patients wait? I mean, waiting to be admitted or transferred or whatever.
For certain populations, sometimes it can be days. I've seen 48 to 72 hours for some patients. The average patient can be anywhere from 12 to 24 hours to be in the ER before they get an inpatient bed.
Wow, it's unbelievable. And people stacked up in the waiting room, I suppose, waiting on beds from out there also.
Definitely. And, it's kind of hard because, we as healthcare providers, we genuinely want to help and we want to take care of these people that we know are sick. It's kind of difficult to do when we have nowhere to place them. We're kind of limited on our resources with staffing and, they get frustrated. So in turn, it makes our job harder.
Sure, right. Are they doing any kind of a fast track process where the nurse practitioner or the PA or whatever can see the patients and get them out, or not so much?
We do have a kind of a fast track area. I can't remember off the top of my head exactly how many beds is in there, but I think it's like 6 or 7. So we try to put the lower acuity things through there. Sometimes we end up bogging it down with sicker patients simply because we need to put them somewhere. And then we also have PIT, so physician in triage. So we have some days we have a physician out in triage that'll see the easy stuff, ankle sprain or a simple laceration.
Yeah, that sounds ideal. Is the setup still that the physician has to see the patient even if you've already seen them?
Yes. So, for our hospital, that's the way they have it set up in the emergency department, which I think hampers our throughput and patient flow because, there's a lot of patients that a NP or a PA could easily see in disposition without a physician involvement.
Sure. Do you know what's behind that for them? Is it a liability thing or a reimbursement thing?
I think it's probably a little bit of both. Also, some of the upper medical staff and management just haven't gotten on board with mid-level and advanced practice providers to fully know, I think, the scope of what we are actually capable of and what we're trained and educated to do. So hopefully, we're working on it. We're trying to get them on board. And I think if we can kind of prove we can be productive and actually help with patient throughput, that would be very helpful.
Right. Yeah. I would think just from a reimbursement point of view, even if they're being reimbursed less per patient, if they could get more patients in and out, seems like things would level out.
Yeah, exactly. Even if a nurse practitioner or PA sees the patient and discharges them, that keeps them from eloping. The hospital wouldn't get paid at all because the patient would end up leaving, due to the extended wait time. So I think it would be very helpful.
How often are patients leaving without ever being seen?
The system we have right now, we have nurse practitioners and PAs in triage. So from the moment the patient hits the door, they're triaged by a nurse and typically a nurse practitioner. We only have, I think, 1 or 2 PAs right now, but we do a medical screening exam. So once we see the patient and we get things started, we get started with labs and diagnostics. Technically, they aren't leaving without being seen, so they have been seen by a provider. So the numbers may be a little bit skewed there, but as far as actually getting a thorough exam and completing their treatment and completing their evaluation, I don't know those numbers. We call those elopements, because they've technically been seen by a provider.
Going back to your own career path, what was it that attracted you to emergency medicine in the first place?
I started off my career as a physical therapy assistant. And, my view of nursing at that time was a little different. And I remember saying the words, I don't ever want to be a nurse because, obviously I ate those words, but I was seeing the floor nurses and it wasn't appealing to me. But I had a hard time getting a full time job as a physical therapy assistant So I ended up getting a job in a doctor's office. And the physician that I worked for, he really wanted me to do kind of everything in the office. So I learned everything from procedures, drawing blood, giving medications. I kind of did it all. And at that point, I was like, well, if I'm going to do this, I might as well go back to school. So, in order to do that, I went to work at an urgent care so I could work weekends while I was going through the school. And I kind of got bit by the emergency medicine bug, that kind of more fast paced excitement, a little bit of adrenaline when you have a patient that comes in sick and you had to call the ambulance. And I was like, oh, this is really cool.
Looking back now, how do you feel? What keeps you around, I guess is what I'm asking.
Yeah. So like the other day, I had a really great shift. I had, the people that I work with, I think are probably one of the biggest things. I enjoy working with a lot of the doctors and nurses that I work with, the techs. We have a great group. So I had a really good shift the other day and we were really busy, but I actually felt, that I was helping and what I was doing was useful. I think that feeling keeps me going. Obviously there's some days that are better than others, but you kind of get that satisfaction from feeling like you really helped someone. And I think I still like the adrenaline also. It's still exciting because I learn something new every single day.
That's amazing. I'm so glad to hear that there's still some enjoyment and excitement, and I love hearing that.
It's been tough the last several years. COVID, COVID, I think really hurt a lot of healthcare workers. There were points when I was just ready to leave medicine altogether, and I think you and I had talked about that personally before because it was so difficult. The uncertainty and the unknown. You didn't know what you were dealing with. Yeah, there were times when I just wanted to take off and open a bar in Costa Rica and be done with medicine altogether.
Sure. What kept you from doing that? I mean, realistically, you could do that.
Yeah, I could. But there is, financial stability in medicine. I know I will always have a job. There will always be work. And for me to go off and find another career to, I guess, pay me the same kind of level that I'm at now, I would have to go back to school or, find a whole new career path, which is kind of daunting.
Right. Yeah. Looking back now, if you were talking to little April, physical therapy assistant April, what advice would you give yourself as far as how to keep showing up every day, or about your career path, or what would you do different? I mean, anything.
I wish I would have known, I guess 20 years ago, I probably would have gone to medical school, but also I don't know, I've really enjoyed the path that I have. Doing the flight nursing and flight medicine that's one of the best jobs I've ever had, and I wouldn't have gotten that opportunity had I been, a physician. I guess I would tell little baby April, to make sure that you have the proper balance with, work life balance, enjoy things outside of work because they will let you work and work and work and work yourself into the ground. But at the end of the day, you have to make sure that you're taking care of yourself and spending time with your family and friends, outside of work.
Yeah, I think that's huge. I wish you would go back and tell little Jody that too. I definitely fell into that trap with the ambulance service. They, like you said, there's always a shift available, and you can always go make more money, and they're never going to tell
Yeah,
you no.
exactly. And especially in the beginning, I felt a sense of, oh, well, I'm a trauma nurse. They really need me. But
Mm,
at the end of the day, there's always somebody who's going to be able to cover another nurse, another medic is always going to come along and they're going to fill your shoes.
sure.
So make sure that you're doing things that because you want to and not because you feel like you have to. Feel pressured to fill in that spot because your coworkers are short.
I feel like I didn't really start developing as a person until I was in my, I don't know, late 20s, because all I did was go to school and go to work. And, I guess my whole identity was being a paramedic, and the people I hung out with were paramedics, and that's just kind of all there was.
Yes, exactly. It is. And especially in pre hospital medicine, it's such a tight knit community. All your friends are paramedics, all your friends are, in the ER, in the nursing world. And, you don't really know much outside of that. And it's easy to get caught up in that excitement and that pressure to always work. And, I can always pick up another shift. We really need you. We really need you.
Yeah. And I think it's fine when you're young, but as you get older, that's not, to me, it's not a sustainable way to live.
No, absolutely. And, I still work a lot, but now it is so I can pay for my fun things outside of work.
Yeah. What are your fun things? What do you like to do?
I like to travel quite a bit. So I'm always planning and plotting for my next big trip. My next one coming up, I'm going to England, Scotland, and Wales. So I'm really excited about that.
You've been to some very exotic destinations, right? You've been around the world.
Yeah, I think the last I counted, I've been to maybe a little over 40 countries.
Wow.
Obviously, I would like to hit them all. I don't know that that will ever happen.
Sure. Any experience with medical systems outside of the United States?
Yeah, in the last 2 years, I've gone with a group to Kenya in Africa, and we're doing medical mission trips. I'll go again in February, and that'll be my third year to go. And I have to say, it's probably one of the most rewarding things that I've ever done in my life to see these people who have nothing, but yet they're still happy and they're very content with their life. They're not chasing after the next big electronic or the next new something, but they're still very happy and they are very appreciative of your help. So it's nice to go down there and be able to see patients and help them because they have no one else.
That's amazing. What kind of situations are you dealing with? What kind of patients are you seeing?
The organization that I go with is called Kenya Relief, and they're actually based out of Coleman, Alabama. They're a really great organization. They have a clinic down there, and they see patients, but our group is more emergency medicine focused. So we kind of go out into the different towns, and we'll set up a little clinic. We'll see anything from thyroid issues. They have a lot of goiters because, for whatever reason, the African government has banned iodine in salt. So we
Really?
see thyroid problems. Yeah.
So I tried to find some information about this just in the interest of fact checking, and as far as I can tell, that's not true. It seems like there are legal minimums for the iodine content in salt in African countries, but it definitely seems like a lot of salt that is available in African countries doesn't actually have the minimum required value. So I'm not sure where that information came from. I'll put a link to an article about it in the show notes. I thought about just editing this part out, but if that is a misconception in the medical community, then maybe it's one that needs to be corrected. Okay, sorry for the interruption.
We see some more acute things. We see a lot of malaria, typhoid, some different tropical medicine diseases that we're not used to here, which is pretty cool. A lot of kiddos with just fever and different ailments. A lot of allergies, that kind of thing. We have seen some more acute things as far as hypertension, diabetes, strokes, that kind of thing.
I've always wondered what it would be like going and trying to diagnose and treat things that you've never seen before, as far as different infectious diseases, especially, I guess. Can you talk more about that? What kind of experience have you had with that?
Yeah, and I'm just going to try to convince you to go with us one year so you'll actually get to see it firsthand.
I'd be
um,
open to that. I'd be open to that.
yes, yes,
It
you
might be more
should.
of a liability than an asset, but be
No,
willing to
I
tag along.
promise. It's challenging, because prior to going down there, I had obviously never seen a patient with malaria. You read about it and you read about the symptoms. And after you see 5 or 6 people in a row, you kind of get that clinical feeling. It's like, okay, well, you have fevers and myalgias and headaches and all these kind of things, and it's like, oh, well, you probably have malaria. So we do have the ability to do a rapid blood test. So I think it takes about 10 or 15 minutes. So we have a little lab set up and they go and they get tested. So that's kind of good. You can kind of confirm your diagnosis and say, okay, then yes, I was right. You have malaria. You kind of have to get a little bit of a clinical feeling, but also, you do a lot of reading and a lot of studying about the diseases before you go.
What's it like? What's it like working without CT scanners and all the cool technology?
Yeah, it's definitely you have to rely more on your clinical skills and your experience because you don't have all of the technology. You can't just say, "Oh, well, you're having belly pain. You need to go get a CT scan," which you can write a referral or a prescription, which literally is just me writing on a notepad to get an X-ray and an ultrasound. And there are hospitals that they can go to. Obviously they're limited by funds because they have to pay. If I order an ultrasound, they have to go to a hospital and they have to pay cash money to be able to get those tests. So, if we can clinically diagnose them with something, then we do that. But there were a few people that you send for some diagnostics. I had a lady that she had an acute stroke some months prior, and she was completely hemiplegic and not able to walk, and her family was literally having to carry her everywhere. So that was really sad.
Not carry as in put in their station wagon and take her somewhere physically.
No, like
Carrying
physically.
her.
Yes.
Yeah.
Carrying her, walking, and sometimes they could get ride on a motorcycle.
Wow. Yeah, I'm sure those circumstances do make you more judicious about what tests you're going to order when you know those are the circumstances that people are dealing with.
Yes, absolutely. We had the capabilities to do a couple of different labs. We could check a basic hemoglobin and that kind of thing. But I had to really convince a girl to go to the hospital because her hemoglobin was 4 or 5, and she had malaria. She didn't want to go to the hospital because it would cost money, and she couldn't afford it. So we kind of took up money from amongst our group to help her get to the hospital.
Is there any sort of nationalized health system in Kenya, or is health insurance a thing, or is it just you're on your own?
Pretty much on your own. In some of the bigger cities, like in Nairobi, I think some of the government workers may have some sort of health insurance, but kind of out in the regions where we are, it's not really a thing. Different hospitals are kind of known for different things, so we kind of rely on the locals to say, "Hey, you need to go to this hospital if you have a broken arm, or you go to this hospital to get an ultrasound." So I guess they kind of have their own little specialty, but to my knowledge, no national healthcare system and no, I guess, organized system.
Have you found that you've learned things off on your mission trip that have helped you once you come back and work in your regular role?
Somewhat. For me, as you know, primary care is a little bit different from emergency medicine because I'm not typically managing people's blood pressure or diabetes from the emergency room. So I've had to study up and read a little bit more about those things to work in Kenya. And then I think it helps me when I come home to kind of better understand the more long term kind of care aspect.
You hadn't seen any malaria roll up in the ER in Huntsville and immediately make the diagnosis?
No, I have had a couple people that have traveled, and I guess because of my knowledge of travel, I knew that they were in an area that was endemic for malaria, and recommended we had to send them to an infectious disease doctor because they had traveled without vaccines to I forget, it wasn't Kenya, but it was in Africa, and they were going to an area that was endemic to malaria, but they had chosen not to get vaccines and did not take any prophylactic medications for malaria. So
I just wrote somebody some prophylactic malaria medicine. She was going off on I can't remember what she was doing, but I just had to do that for the first time recently. It's one of those things where I just had to look it up and learn about it on the fly. I didn't know anything about it.
yeah, the CDC website's a good resource. And then at the end of the week, we work really hard and we see a lot of patients, and then we get to go on a safari, which is just absolutely incredible. Getting to see lions and giraffes and elephants, and they're in their natural habitat, and you're getting very close to them, so it's very interesting. It's amazing.
Is that like what I'm picturing from seeing it in the movies, like riding around in an open top Land Cruiser and just
Yes.
seeing random animals everywhere?
Yes, that's exactly what it is. We got to experience there was an elephant that had died of natural causes, but, you know, circle of life, there were a lot of animals feeding on the elephant carcass. So there were several lions that we got to stop and kind of watch. And then, I kept hearing a strange noise, and it was a very kind of high pitched noise. And I was like, well, that's not a lion. What is that? And it turns out that there was a hyena that had crawled inside the elephant carcass and was scared because the lions were getting closer. It's like we were watching The Lion King in real life. It was pretty cool.
I was trying to figure out how to bring the Lion King into this. I'm glad you said that.
Right? I feel that way
That's
every
crazy.
time we go.
It's like a turducken for the lion.
Yes.
Elefina.
And the hyena. That's a good one.
You mentioned your experience on the helicopter a couple of times. Do you want to talk about that?
That was probably hands down the best job I think I've ever had. It was obviously challenging, but we had such a great group. The medics and the pilots and other nurses that I worked with. I think especially pre-hospital, your family. I'm spending 24 hours of time with these people. We eat together, you know, we are family. So
Yeah, I imagine so.
I think it's just like with EMS, you have your pretty much the same partner that you always work with, and you get put in high stress situations together, and it kind of bonds you. And then obviously it's exciting, it's fun. You get to say you ride around in a helicopter, which is just so cool. It's the best feeling.
I'm sure it is amazingly cool. I was too fat to get on the helicopter.
Yeah, that was tough. You always had to get weighed in and have weight restrictions. So that was not fun, but it's part of it.
Was that your full-time thing?
I started off part-time and then took a full-time job, and that's actually why I got my EMT license and then my paramedic license, so I could fill in the paramedic slots when we had them openings. And then, the company I worked for Air Methods. I would, do some kind of regional travel down to Florida and Georgia. Had some great opportunities.
Okay, very neat. Yeah, I guess I didn't realize that a person could do both roles if you have both certifications or licenses.
So if another base, because I got my Florida nursing license, so I could go down there. But if we were short, say paramedic got sick and we didn't have another paramedic to fill in, I could fill in that day as a paramedic just to kind of meet that requirement for the state.
You're a huge asset to them then.
I mean, I like to think so.
Did you stop doing that just when MedFlight shut down?
Yeah, reimbursement is not the greatest in the state of Alabama, so they shut down several bases, our base in Danville and then one in Birmingham, and I think a couple others. And that was really tough, because they came in one day and they said, "We're having a mandatory meeting tomorrow." And at that point, we all kind of knew, but they shut down the base immediately after that. So I
Yeah,
actually worked the last shift at MedFlight 2 ever.
yeah, I remember. I have the impression that it was a very sudden thing. Like people, were kind of left high and dry.
Yeah, they offer you a spot with an open position in the company, but that would mean you're moving to Arizona or Idaho or wherever they may have an opening. So at that point, I was getting ready to graduate with my nurse practitioner degree. So I just chose to stay.
Right. You ever think about going back and doing that anymore now?
Oh, sure. I think about it all the time. But as I get older, it's not an easy job, especially working 24-hour shifts. You get woken up at all hours of the night and you have to be ready at a moment's notice. And that can be tough on your body, and as I get older, it's kind of nice to not have to do that. But I certainly think about it every now and then.
Yeah, I have fantasies of going back to EMS every now and then too.
Well, wouldn't that be fun if we could both get like a part-time or PRN job and we could work a shift on the truck together?
That would be fun. Yeah. Okay, let's do that.
Okay.
I think I have to. I let my license go though. I think I have to. I don't know what you have to do to get it back.
Oh gosh, I don't know.
Yeah, it'll take a while.
All right, we'll work on that.
Although I heard that Himsey might be part of Huntsville Hospital pretty soon.
I also heard that rumor. I don't know how much truth there is to that. I guess probably wouldn't shock me, but I don't know. We'll see.
Somebody sent me a link to like a news story the other day, so I guess it's public information. I guess we're revealing anything.
No, I think I saw that on social media, WHNT or something. Somebody had an article.
Yeah. Did you ever work at Hamsey?
No, I never worked at Himsey. I just did rotations with you and Jim Rashi when I was doing my paramedic stuff.
Oh, that's right. And we work at cardiac arrest together.
I'm pretty sure we did.
Yeah, that's right. I do remember that.
It's been a long time ago.
Yeah. How many of the folks that were around when you started working in the ER are still there?
Oh gosh, there's maybe a handful, maybe 4 or 5. Some of the physicians have been there the whole time, but honestly, not many of them. And a lot of the ones that I used to work with retired. But there's the Eddies who've been there for 40 years and, you know, a couple of those kind of folks, but not a whole lot.
Yeah. You mentioned that before they wouldn't hire new grads. Is that still the case or no?
Oh, no, no, no. You graduate from nursing school, and Huntsville Hospital also has a program that they'll take some of the nursing students and they kind of bring them on in kind of a intern position, and they will let them work. I guess it's kind of like they're precepting, but they're working and getting paid. So I'm not sure if they have to sign a contract or what, but we've had a few of those come through. Especially like our techs that work in the ER that are in nursing school. It's a perfect position for them if they want, if they know they want to stay in the ER, and that way they can get paid and learn the job while they're finishing school. They are recruiting like crazy. So if you are a new grad, we always have positions.
How do you feel about that? I know more experienced people will say like it's so scary that there's nobody around that has a lot of experience, and I guess I have the impression that maybe the nursing care has sort of gone downhill just because there are so few experienced people around. I mean, has that been your experience or no?
Yeah, I think we've definitely seen the potential for disaster and some close calls where, we have a nurse who's been a nurse a year who's training new grads. And, the saying is, you don't know what you don't know. So these people are training to the best of their ability, but also they can't train them and teach these brand new grads what they don't know. So if you don't even know it exists, you can't learn about it and teach other people. So there's definitely some deficits there. But for the most part, I think they're very willing to learn and they will ask questions, and they're not scared to ask for help. So I think that's key. There's always going to be a few that are just cocky and they think they know everything and they're not going to ask for help. And those are the ones that are dangerous to me.
Any specific examples that come to mind of near disasters or actual disasters?
Well, yeah, they will have a patient who's, maybe hypotensive or hypoxic. And instead of saying something about it, they will just kind of let it ride because they don't realize the importance of it. Or so, for instance, we had a patient, this was, I think, a couple of years ago, that was boarding in the ER and they were diagnosed with a non-STEMI, and cardiology had seen them and ordered a heparin drip. Well, the nurse didn't think it was important to start that drip because they're like, "Oh, that's an inpatient thing. I don't need to start that."
Oh, wow.
Yeah, and the patient actually kind of worsened and their troponin doubled and they were having chest pain, and the patient ended up having to go more emergently to the cath lab than we were expecting because the heparin didn't get started. So I think that's a knowledge deficit, that they didn't realize how important the heparin was in that situation.
How long did they go without the drip that they should have had it?
Oh, I'm pretty sure it was hours.
Wow.
Oh yeah. It was a thing that in their minds, that's an inpatient thing. They can start that when the patient gets upstairs. And for some things that's okay, but obviously in that situation, a patient with a non-STEMI that was having occlusions needed that heparin, and I think that delay definitely affected their care.
Wow. Do you know what the outcome was for the patient?
I think they went to the cath lab and they got cast. I think they got a stent and they were fine. But it was just the fact that instead of a scheduled procedure, where you're in PO and you have all the preparation, it was a more emergent procedure.
Yeah, that kind of thing is scary. I ran into that some when I worked in PACU. Obviously, not with critical things like that. We didn't, they didn't let us take care of super sick patients a lot. But there were times when the right thing to do is to switch over to, inpatient mode because the patient like has a medicine due or, there's not a bed upstairs, and so now it's been 3 hours since their surgery, and they're supposed to be getting this stuff, and there was still that mindset of like, no, we don't do that. They do that on the floor. And I notice a lot too that people will hide behind that. They'll say, "Oh no, I work in PACU. I don't do that." And it's like, well, yeah, but we're all nurses. I mean, at the end of the day, we have to do the nursing things for this patient, and anybody can do that. It doesn't matter what unit you work in.
Exactly. At the end of the day, we're all here to take care of the patient. It doesn't matter what your title is or where you work.
I guess you transitioned from RN to nurse practitioner in the same unit that you worked in. Was it challenging for you to kind of get out of the RN role and into the NP role?
It was because I think a lot of it was I felt a little strange. For instance, if I ordered an EKG as a nurse practitioner, I know how to do that. I'm fully capable of performing an EKG and doing it. So it felt strange for me to ask somebody who was my coworker as a nurse, like, hey, would you please do this? When I know that I could just do it and get it done. So it was kind of that weird transition. But at the end of the day, I had to kind of realize, well, okay, I have other things that I need to be doing. I need to be seeing these other patients and doing other things. And a tech or a nurse could do that, but they can't do my job. So I kind of had, at the end of the day, make sure my job was being done before I would help others. And I still now, if an EKG needs to be done and there's nobody to do it, I'll be happy to do it myself. Or if I need to help clean up a patient, I'm going to do that. I'm not going to just let them lay there. But at the end of the day, it's kind of hard to transition to ask people to do things that I know I'm fully capable of doing myself.
And I remember a couple of times just when I was doing my training with you in the ER where there were times when you were like, I sure wish I could just open the Pyxis and give this medicine and not have to wait on somebody else to do it.
Yeah, it's kind of a weird transition there, but I think I got used to it by now.
I'm sure it is weird. One day you come in, you're an RN, and the next day you're NP, and it's the same people, like, the same dynamic. I can see where that would be challenging.
Yeah, I think for me personally, because I had more experience than the majority of the nurses that I'd worked with, I think they had already kind of looked up to me as more of a mentor anyway, because I was doing relief charge and that kind of thing. But there were a couple, especially the ones that were older than me, as far as like experience wise, they had been in the department longer. I got a little bit of pushback from a couple of them. We just kind of worked through it. I think as long as you're respectful towards other people, I think that goes a long way. But there were a few that I think gave me a hard time just because they could.
Yeah, and I'm sure that's weird for them too if they're super experienced person that was there when on day one when you showed up, and now you're the one writing the orders. I'm sure that is a
Sure.
little hard to digest also.
Yeah. It is a transition because you look at that person and I'm sure in their mind, they're like, well, I know more than that person. I've been here 10 years longer than them. So it can go both ways. I can see how it's difficult for both sides.
Do you see that at all with like new nurse practitioners or PAs or physicians for that matter that hire in from somewhere else that are not known?
Oh yeah. Um, I think the personalities in the ER and EMS can be pretty strong because we kind of have to be a more assertive group. So you certainly will have people that come in, even new physicians, and the nurses will kind of be a little condescending because, like, oh, well, why don't you know that? You should know that. Until they kind of get used to working together. And, I guess unfortunately, you almost kind of have to prove yourself to prove that you are competent and that you know what you're doing. And then finally, you'll kind of be accepted. But it can be a tough place to crack.
I wish I could just take a GoPro or something into that ER for anybody that's never been around an ER or been in there. It's such a different world in there.
Oh, yeah. I think that would be really interesting because, the general public, they just don't get to see what we see. I had a patient's family member the other day that apparently was angry with me, so she told one of the other nurses that I was I don't know if you cursed, but a B
Oh,
word.
totally. Yes, you can say whatever you want.
Anyway, yeah, apparently this family member called me a bitch because she didn't like what I'd said. And I was not ugly to the person at all, but I was just kind of straightforward. And I was like, the general public, you could never walk into a grocery store. You could never walk into Walmart and just curse people out that work there just because you don't like what they said. It's kind of a jungle. So I wish people, the general public, understood a little bit more what we deal with.
It is the jungle, and you are not a bitch unless unless your personality's totally changed in the whatever month and a half, 2 months since I saw you last. You are not a bitch.
I appreciate that.
There are those in working around, I guess, every situation that would probably be a well earned
Oh yeah.
insult, but you're not. You're definitely not one of those people. And I'm sorry you had to endure that abuse.
Yeah, I guess you just kind of have to let it roll. But at the end of the day, it's like, it kind of bothered me, but it kind of didn't. I guess in the fact that, well, I hate that that was their opinion of me. But also that the lady that said it, I didn't have any contact with her whatsoever. So I guess the patient had said something that made her think that I was being a bitch. So I'm not sure what happened.
I
But
see miscommunication.
yeah, I'm sure. That compounded with their probably 8-hour wait in the emergency department did not help things, so
That's one thing that you couldn't get from watching a video. Or I guess there's plenty of shows where they're in the ER and showing real things, but you don't feel the tension if you're just watching it on television. When you walk through there, you can feel the anger and the pain and the frustration. It's like dripping off the walls. It's amazing.
Oh, yeah. It's very, very tense environment.
I used to hate walking out in the waiting room when we have to draw a patient. Man, you can.
Oh.
I don't know why there's not a cage out there for the staff to hide behind. 'Cause, man, those people are mad out there.
Oh, yeah. I also still hate doing that because we've remodeled an area, and to get to that treatment area, you have to walk through the waiting room. Oh, you get some dirty looks.
Oh, I'm sure. Of course, a lot of times they're altered or there's something wrong with them, like they're not in their right mind and they're acting out. But a lot of times, but sometimes not so much. Sometimes they're just being assholes.
Yeah.
That is hard to take. Even in my little bougie primary care situation, people act a fool sometimes, and it's just like, what are you thinking?
I will never understand that, especially, in a primary care situation like with you. I will never understand that because you are literally there just to help them.
Right. And
And
for the most part, there's not even anything wrong with them, you know? I mean,
yeah,
compared to what you're seeing, you know?
I don't know where people think it's okay. I will never understand that.
I was just talking about this with one of the nursing instructors last night, how some of the students can just be so savage and rude and awful, in school, like to the instructors
I
or to each other.
Oh my gosh, that just absolutely blows my mind.
Have you ever been in a situation in the ER where you really felt unsafe? Like somebody
Oh,
was going to harm you?
oh yeah, oh yeah. Years and years ago at the other hospital I worked at, we had a patient that was a regular, and he was, coming in asking for narcotics all the time. And this one particular evening, the physician was like, "No, we're not giving you any narcotics. You need to leave." And he says, "Fine. Well, I'll just go out to my car and get my gun, and I'll come back in here and kill every one of you." So we ended up calling the police, and they came and talked to him, and he had a shotgun in his trunk.
Oh my.
So it ended up going to court. So we had to go to court to testify, and essentially nothing came of it. They told him he was trespassed, that he couldn't come to the ER unless it was an emergency, which he was there the next week.
Hmm.
And yeah, I kind of felt that there literally was no protection for us. I've been bitten, kicked, spit on, punched, and that's not outside of the norm. Probably anybody that works in the emergency room, you can ask them, and they've been in some sort of similar situation.
Yeah, and that's so sad that it just is. So, like, you laughed when I asked the question. It's just such a routine part of the job. It's awful.
Yeah, and I understand it. Like you mentioned earlier, if you're altered, or if it's a little old lady with dementia, then then I'm not going to be so worried about it. You just kind of take it as it is. You try to protect yourself. But, we had a guy just the other day, which of course he was on drugs, but he was angry for whatever reason and kind of charged at me like he was going to hit me or get in my face. So I just had to put my arm out and kind of back up, just call security. And that's almost a daily occurrence.
Yeah, that just makes me, I don't know what to say. It just makes me feel bad. It makes me feel bad that people have to endure that.
Yeah, it is sad, with more mental health issues that we have in society and drug abuse. It's just gotten worse and worse.
Yeah, and it sucks that there are not more resources, but it also sucks that there's not more protection for you guys. I remember when they started going, hey, we should probably check these people when they come in on the ambulance and wanting people and checking bags. And that's still a pretty new thing. Before that, it was just like, hey, come on in, whatever.
I think especially for EMS and pre-hospital, you're walking into situations that you have no idea what the situation is going to be like, how angry those people are going to be, and are they armed?
Yeah, the pre-hospital folks are super vulnerable. I mean, the plan is you don't go in if there's any concern, the police go first and you don't go until they say it's safe. But I mean, in practice, who knows?
Well, sure. I mean, but anytime you're walking into somebody's home and there's an emergency, so people are excited, there's adrenaline, and if they feel like you're not doing things quick enough or perfect enough, whatever, if they get angry and they're going to take it out on you, you just never know.
And you're very vulnerable, because you're in the mindset of you're there to help. But then the other part of it too is you kind of get your guard up so much that I've overreacted a couple of times. One time we were in this lady's house and that some kind of domestic thing had occurred, and I was squatted down in front of her just doing my thing, and she was describing to me what happened to her, and she drew back, demonstrating what somebody was doing to her. But in the moment, I was like, "This bitch is about to hit me," and I caught myself before I freaked out about it. But it did, it just in that split second, it did freak me out. You also kind of get in that mindset where you're constantly looking for somebody to surprise you or whatever.
Yeah, you constantly have to be aware of your surroundings and what's going on because you just never know what these people might do.
We got flagged down one time on the way. We had done I guess at the time it was called First Heart. We had done one of those transfers and we were taking the truck back to the station from the hospital to wash it. And we drove through downtown and somebody flagged us down at one of the bars, and we stopped and this drunk lady was laid out on the sidewalk, And so I'm squatted down to her, next to her, talking to her, and I'm writing on the back of my glove. I'm not looking at her. And she reached up and touched my face, and I didn't see it coming, and I wasn't expecting it. And just reflexively, I just slapped her hand, and it went bam and bounced off the concrete. And it was embarrassing, but I mean, you're just more on alert, I guess.
Yeah, well, I mean, that's your instinct to try to protect yourself, especially if somebody's coming at your face.
And then I was like, "Don't touch me."
Yeah, I do
It's
the
not a good
same.
PR. Maybe that was before everybody had a camera in their pocket. That was hopefully.
Probably.
Doing what you've done for so long, has it affected your personality?
Oh, definitely. When I first started and I worked in the doctor's office however many years ago, all these sweet little people would come into the office and they would bring you tomatoes from their garden and they would bring you Christmas presents and they were so sweet. So in return, I was super sweet back. And then, you get into the emergency medicine role and you get a little hardened. And, I still try to be very kind and very empathetic to my patients. But also at the same time, I've learned to set boundaries. When people start cursing at me, I will tell them flat out, I have zero tolerance for that. I will help you all that I can, but I'm not going to put up with that. And you're not going to call me or anyone else names. Now, do you want to be treated? 15 years ago, I probably would have never done that. But, you have to kind of learn to set boundaries and be a little more assertive and more aggressive, in the emergency environment. Because if you don't, people will just, they'll just abuse you.
Yeah, and I think people who are attracted to medicine are you want to care, you want to help, and you're not there to be confrontational or whatever. I have a really hard time saying no to people.
Yeah, exactly. You're there because you want to help and you want to do things, and sometimes it is hard to say no when they come in and ask you for something that is kind of a ridiculous thing to ask for, but at the same time not totally unreasonable. But
Right. Yeah,
yeah,
when it's a gray area, yes.
yeah, exactly.
Right, if it's totally over the line, yeah, but most things are not. Most things are somewhere in the middle.
Yeah.
During the whole COVID thing, I'm very, like, I was the first person in line for every vaccine, like, I'm super pro vaccine. I was not on team ivermectin. I'm not, I was like, we're only listening to the mainstream medical, like, that's just who I am. But
Yeah.
when they started forcing people, when the company started saying, we're going to fire you if you don't get a vaccine, I thought, "Ugh, I don't like that. Like,
Yeah.
I want people to go get vaccinated, but I don't want anybody to be forced to do it." And so we would have patients come in and say, "Hey, can you write me a letter, for a medical exemption so I can try to get out of getting this vaccine?" And my
Yeah.
approach to that was to hope that they would lie to me and tell me that there was some real reason they didn't have to get a vaccine. So I'd kind of do well, if you had any trouble with a vaccine before, any flu shots or anything, anything that's ever bothered you about a vaccine, and the smart ones that smelled what I was stepping in were like, oh yeah, they would kind of get it, and then I could go, okay, well, yeah, this patient shouldn't get a vaccine.
Yeah.
But some of them didn't. Some of them would be like, nope, never had any problem at all. This one guy was like, I mean, I'm like almost literally comically like winking at this guy, going, "Are you sure you're not?" And he's like, "Nope, I was in the military. I've had every vaccine on the face of the earth. Never had a problem with it." I'm like, "You're not helping me here. Like, I'm not gonna. You have to lie. I'm not going to lie, but I'm not gonna. I don't know. I don't even know where I was going with all that."
No, I totally understand what you're saying because yeah, that would be a perfectly gray area. Like you want to help them out, but at the same time, you have to try not to bring your own personal beliefs into it. But also, to me, COVID was just. I hate that it got so politicized, and
Oh, I know.
instead of leaving medicine up to medicine, it was political, and it just went nuts.
Real nuts. Yeah. That's one part of going through a pandemic that I never would have anticipated was that part of it.
Yeah,
Because when
that
you read about it in textbooks or history books and stuff, it's like, oh yeah, there was polio, and then there was a vaccine, and everybody took it, and now there's no polio. They kind of left out all the part about people not trusting and going off on their own crazy tangents, and yeah, I would
which
not have anticipated
sure
any of
it
that.
happened. Back in gosh, when was polio around? I don't know, remember when the vaccine was invented, but I'm sure there were quack doctors who came up with their own special remedy to try to sell it and make money. But you're right, it's not in the textbooks. And looking back at history, I just wonder how it will be perceived in 10, 15, 20 years about the COVID pandemic.
We should be alive long enough to see how they write it up and see how it turns out.
Yeah, that would be interesting. If I was any
Um,
good at writing, I'd write a book about it.
for anybody who's new to emergency medicine or thinking about going into emergency medicine, can you talk about your process of just assessing a patient? Like, what's your approach?
If it's more a lower acuity issue, you tend to be a little more focused. I think in nursing school, medic school, they teach you to do this broad, head to toe exam, and that's just not feasible. So if a patient comes in, say they're complaining of chest pain, I'm going to do more of a cardiac focused exam. But if someone comes in, say they're altered and I have no idea what's going on, you may need to do a more complete total physical exam. Because if you're not, you're probably going to miss something. So I think when a patient comes in and, you start off immediately thinking, okay, well, what could this be? What am I going to order? What am I going to anticipate? Because right off the bat, I think, okay, well, this patient's going to have to be admitted or maybe they're going to be discharged. And then you just kind of start your assessment and thinking about diagnostics, what you're going to do, what you're going to order, and then kind of go from there.
Any common mistakes that you see new nurses, mid-levels, physicians making as far as things that are commonly overlooked, or techniques that are useful that people don't know? Any little pearls like that? Any tips?
In the beginning, I always tell, if I have a student, I'll tell them I would rather it be quality over quantity. So I'm not wanting you to go see 100 patients, but I want you to go see maybe a handful of patients, but I want you to really think about it. Because in the beginning, you don't even know, like I said, what you don't know what you don't know. So if you don't know that somebody comes in with chest pain, if you don't even think about it being a pulmonary embolus or, a coronary dissection, because you don't even know those things exist. I think you have to continually learn and read, and you're always going to grow and get better. So, I think it's hard as a brand new grad because if you don't have a good knowledge base and experience, if you went to nursing school and you worked a year or two as a nurse and then you turn around and went to practitioner school, I don't think that you have the knowledge base that you need to be an advanced practice provider.
Right. Yeah, I agree with that. I think it's insane that they let people just go straight on through.
That's not what nurse practitioner school was set up to be. The PA program is a little bit different, but also I've seen, we had a brand new PA a few years back that didn't know what a sliding scale insulin was, just simply because he'd never worked. That's more of a nursing thing.
Sure.
And, and during his rotations, he had no idea what that was. So there's just a little bit of a learning curve there. But if you're not an experienced nurse, I don't think you should be going to NP school.
Yeah. I don't understand why there's not a requirement that you, like CRNA, where you have to work for a certain period of time before you can even think about it.
Yeah, I definitely think there should be. And then also, you can't work as an RN in a outpatient clinic in a urgent care and then think that you're going to go through an acute program and be able to function in an ICU or an ER setting. It's just completely different.
Yeah, sure. I feel like at least there's more of a trend toward you have to have a degree in whatever you're going to work in. Like you can't just get your family nurse practitioner and then go do something super acute and specialized.
Yeah, exactly.
Yeah.
Well, also people, they can get into an acute care program, but then they want to work in family medicine. And I was like, you have zero experience in family medicine. It's totally different.
Oh, yeah, definitely.
Probably needs to be a little more regulated and a little more stringent, especially with some of these different schools, online schools and whatnot.
Yeah, because they're not doing the profession any favor by cranking out a bunch of NPs who don't know anything. It gives us all a bad reputation. And maybe I'm an NP who doesn't know anything, but
No,
I'm not saying this. I'm not saying I'm holier than anyone else, but it's not
no,
doing the
but
profession any favors for sure.
yeah, I think at least if you're experienced, you know where to go to find information. I came into the NP role with, I think, 12 years of nursing experience, and I felt so dumb for at least a year and a half. I just felt like I didn't know anything. It was a big learning curve.
Yeah, I felt that way in family practice for a long time. I've been doing it for 5 years now, and I'm comfortable now.
Yeah,
Now that I've essentially done a residency, go figure. I'm
exactly.
pretty comfortable. And I guess I had 5 years of RN experience and 15 years of EMS prior to that. And the idea of me coming out of school and practicing independently is insane.
But I think the difference is you had that experience to know if a patient walked into your office and they were acutely ill, maybe say they were having chest pain, you could confidently, say do an EKG in your office and say, okay, well, I think we can handle this on an outpatient basis, or no, I think you need to go to the emergency room. And that I think comes with your background and your clinical expertise.
Oh heck yeah, I'm all over something like that. But like telling you what to do about your rash, I don't know. Go to the dermatologist, I guess. I don't know.
Half the time they don't know either. They're going to be like, oh, well, we're going to biopsy it. So
I
think
have
some of the
strategies for that now, but yeah, at first, like I wish somebody would come into the office and code so I'd know what the hell to do.
exactly. Like, I don't know how to treat your rash, but if you die, I got you.
I mean, yeah, really. I wouldn't have done family medicine if not for Dr. James kind of recruiting me. But having him there right across the hall was essential. I couldn't have, I had to learn a lot before I was comfortable doing that.
Yeah, but I mean, I think that's a good thing. And also, I feel like you are the type of person that's not going to go rogue and be like, oh, yeah, I totally know how to take care of this. You're going to be like,
Sure.
No, I don't. I'm going to ask questions and I'm going to ask for help. So,
Yeah, I hope so. I hope I'm that kind of person.
yeah, I think so.
if you could speak to all the primary care providers out there as someone who works in the ER, what would you like us all to know about seeing sicker patients and deciding when to send people to the ER? What are some common things that you see there that people screw up?
I have zero trouble with somebody sending somebody to the ER if they're sick and they need further care than what can be provided in the office. Where I get frustrated is they're not clear about what's going to happen. We have so many patients that will show up in the ER and they're like, "Well, my primary care doctor sent me." So they expect that they're just going to get moved to the front of the line and they're just going to go, go straight to a bed. Or they say, "Well, my doctor wanted this or X, Y, and Z. Well, my doctor told me I needed an MRI." Well, maybe you do, but maybe it's not acutely needed today. Maybe it's something that can be done down the line. And they don't understand that because they're like, "Well, that's why my doctor sent me." So I wish they would be more clear cut about the expectations that they're going to have when they show up to the ER. And also write a note, write or send a note saying, "This is what I suspect. This is why I'm sending the patient." Even if you just handwrite a note saying the patient has a sodium level of 125 and they need to be admitted. Because a lot of times people will show up and they're like, "Oh, I had some abnormal labs." Okay, well, what were they? Well, I don't know. That just causes us to have to spend 30 minutes trying to get on the phone and try to call an office and try to get a hold of somebody who can tell us what's going on. And then, it just delays care and then ties us up for a long time for something that could have been simple.
Sure. Yeah. Yeah. Those are great tips. Are there still doctors that come admit their own patients to the hospital?
There may be maybe one, I think, at this point.
Hmm.
And bless his heart, if he's not retiring in the next year or two, I'll be surprised. He's very old school, and but pretty much, I think everybody just sends their patient to the hospital to be admitted by the hospitalist.
When I did a rotation with Dr. she was still, her patients would call and tell her something was wrong, and she would admit them to the hospital like they didn't have to go through the ER. She would call and get them a bed and admit them and whatever, and then go see them later that night. And it was neat for me to get to see that because I feel like that's not what most people do anymore.
It's great when they do that because I think she still does because she knows her patients. Half the time she's been treating them for 20 years or more, and she knows exactly what's going on with them, what their background is, and it's simple for her to do that.
And I would say too that I don't seeing it from that side. It's maybe not as great because she's seeing patients in the office, and so somebody calls in and she thinks they have a PE, and so she calls and gets them a bed and whatever. Well, then we're busy doing whatever we're doing in the office, and so 2 hours go by and the nurses are calling, going, "Hey, we need orders on this patient. What do you want?" Like they're in the hospital, but she's not paying attention to them. And then two, she finishes in clinic, goes and eats dinner, and then she's up there at 11 o'clock rounding, and that's no way to live.
Yeah, and I think that's probably why the big movement away from primary care doctors admitting to the hospital because you have to learn a whole completely different computer system and now it's complex and you have to know all the rules, you have to know which orders you have to put in order to even get the patient admitted. So I can see as a primary doctor not offering that service because it's so complex nowadays. And if you admit to, say Huntsville Hospital and Crestwood, you have to learn both systems. And like you said, you're going to be at the hospital at 11 o'clock at night, and then have to turn around and be in clinic at 8 o'clock the next morning. It's just not feasible.
Right, it's crazy. Yeah, Dr. James took over the practice of an established doctor, and he actually did that for a while. He would, take care of his own patients in the hospital, but it was a work life balance for him. He has young kids. He didn't want to be up there messing around at the hospital all night. And the interesting thing about it from our side of it now, from primary care now, is that a lot of patients still think that's how it works. Like they still think that I'm supposed to show up there and tell everybody what to do, or people will say, "What do you mean? What happens when I go in the hospital? What do you mean you don't take care of me in the hospital?" And it's like, well, I mean, I want to go home first, and second, I don't even know where the bathroom is in the hospital. Like, you don't want me taking care of you.
Exactly. Well, I mean, it's gotten so complex.
I took over from a very old school physician, but she didn't have admitting privileges at the hospital either. And a lot of her patients still thought that she would be up there taking care of them, which she would go up there and like make a social call, and
Yeah.
act like she was doing something, but she was not actually their doctor in the hospital.
Patients do kind of have that misunderstanding because, I mean, if you are a layperson and you don't know how the hospital works now. And I guess back in the day, you expect that your physician would show up, and that's just not the case anymore. And we still have so many people that do that, and they'll show up and be like, "Yeah, my doctor sent me." I'm like, "Okay, well, we're gonna get started on your workup." And they're
Yeah,
like,
we're
"But
gonna
no, my doctor sent me." I'm like, "Yes, I understand. And I'm
sure.
sorry that you think they're gonna show up, but they're not." They're like, "Oh, but they talked to so and so. So and so's gonna, or they'll call a consultant. Well, they talked to, the cardiologist and they're supposed to meet me here." Oh no. That's just not how that works.
First of all, I try not to ever send anybody to the hospital unless I really, really think they need to go. And then I try to tell them, like, you're going to be there all night and this is what's going to happen. And, I try not to create unrealistic expectations. And I do send notes and demographics and we call a report over to the hospital. And
Yeah,
I'm
see?
trying to be helpful, which, my office is directly across the street from the emergency room. So I'm definitely not calling an ambulance if I can, if I can get out of it. I've pushed them over there in wheelchairs. I've driven them over there in their own vehicles and driven them over there in my vehicle. Like I called an ambulance one time. It was for a guy who had COVID right, at the beginning of COVID, and he had like 0 platelets, and he was very old. And I was like, okay, you need to go to the hospital, like not in Decatur. And so I
Yeah.
did call an ambulance to come get him and take him to Huntsville, and then he died. So
Oh god.
I felt like that was justified.
Yes,
Um,
absolutely.
But yeah, I'm trying not to. I'm trying not to be the primary care person that creates creates more work for the ER people. Well, I feel like this is probably a pretty good place to stop. Is there anything else that you wanted to cover? Anything else that came to mind? Anything else you want to say?
No, I don't think so. I appreciate you asking me. I consider that a big honor coming from you wanting to interview me because I've always thought so highly of you.
That's so nice of you to say. Thank you, and it's an honor to me that you would give me so much time because you're one of my true mentors and heroes and friends in medicine. So it means a lot to
Oh,
me that you would come on also.
well, I hope a lot of people want to listen to this.
We'll have to do this again. I feel like we could keep talking for the rest of the night.
Oh yeah, easily. We'll just have to do dinner.
That's definitely your compensation for doing this. So you let me know the time and place and we'll make it happen.
All right, anytime.
All right, April Klar, thank you so much.
Good night.
Good night. Can you still hear me?
Yeah.
Okay. The thing froze on my end, but I guess we're still hearing you. Okay. Oh God, what's happening? Can you still hear me?
Yeah, I can hear you, but you are frozen on my screen.
Huh. Um. hmm. I'm not sure what's happening. Hello. Um. Oh yeah, I don't know what's happening and I don't know what to do. My monitor just went black, but obviously things are still on because I can still hear you. You can still hear me.
Yeah.
Huh. Well, okay. Um, okay, I'm going to say what I was about to say, and then maybe we'll just go on and wrap it up in case none of this is being recorded anymore.
Okay.
All right, that does it for this episode of Knowledgeable Provider. I'm your host, Jody Marks. Thank you so much for listening. Don't forget to like or subscribe or follow and leave a nice 5-star review. And as always, stay safe, take care of yourself, and take care of your patients, in that order.